An 18-year-old student comes to the GP in late spring with sneezing fits, a blocked itchy nose, and watery itchy eyes. He says it's worse outdoors and first thing in the morning. He's convinced it's another cold, but it's happened every year for the last 3. You suspect allergic rhinitis, but how do you separate it from viral rhinitis? What are the classic exam signs, and what is the management according to NICE guidelines? By the end of this high-yield summary, you will have a clearer understanding of allergic rhinitis and be ready for any UKMLA scenario. Allergic rhinitis, often called hay fever, is an IgE-mediated inflammation of the nasal mucosa triggered by allergens like pollen, house dust mite, or animal dander. It's often associated with allergic conjunctivitis, so if you hear itchy, watery eyes alongside nasal symptoms, your suspicion should shoot up. Allergic rhinitis is very common, with an incidence of 2,000 cases per 100,000 person years. The peak incidence is around the 20s and 30s. Risk factors you should remember include atopy or a family history of asthma, eczema, or allergies, allergen exposure, which can include pollen, dust mites, mold, or pets, any exposure to air pollution and tobacco smoke, which can worsen symptoms, and finally, allergic rhinitis often coexists with asthma, following the one airway concept. Moving on to the anatomy and physiology. The nasal lining is packed with blood vessels, mucus glands, and immune cells. Its job is to warm, humidify, and filter air. In allergic rhinitis, that lining becomes inflamed and leaky, which can cause congestion from swollen mucosa, watery discharge from increased secretions, and finally an itch and sneeze from irritated sensory nerves. Allergic rhinitis is a type 1 hypersensitivity reaction. The allergic response happens in 2 phases. First is the early phase, which occurs within minutes. When an allergen is inhaled, it cross-links IgE antibodies on mast cells. This triggers mast cell degranulation and the release of histamine. Histamine is what causes the classic symptoms, which include sneezing, nasal itching, and a watery, runny nose. Then comes the late phase, which happens hours later. Cytokines released during the early response recruits eosinophils and other inflammatory cells into the nasal mucosa. This ongoing inflammation leads to persistent nasal congestion and blockage. The classic symptoms include sneezing, which occurs in bouts, itchy nose and sometimes itchy palate or ears, clear, watery rhinorrhea, nasal congestion, red, itchy, watery eyes, which are very common. And clues on the exam can include allergic shyness, which are dark circles under the eyes, an allergic salute, which is a nasal crease formed by upward rubbing of the nose, and finally, the nasal mucosa can look pale and boggy. Most of the time, diagnosis is clinical, which means that the history is everything and investigations are not normally required. If confirmation is needed, especially if symptoms are severe, persistent, or diagnosis is uncertain, you can use skin prick testing or specific IgE blood testing. But you don't need routine bloods or imaging for straightforward allergic rhinitis. Next, diagnosis and differentials. The key differentials that you need to know are firstly, viral rhinitis, which is the common cold. This usually comes with a sore throat and systemic malaise, and crucially, it resolves within 7 to 10 days. There's typically less itching, and the eyes are much less prominent compared to allergic rhinitis. Next is non-allergic or vasomotor rhinitis. This isn't driven by allergens. Symptoms are often triggered by things such as spicy food, strong perfumes, or cold air. There's no itching, no clear allergen link, and antihistamines are often less effective. Then there's acute bacterial sinusitis. Here, patients usually have facial pain or pressure, discolored nasal discharge, and sometimes fever. The key distinguishing feature is that symptoms persist or worsen beyond 10 days. Now it's vital to recognize the red flags. If symptoms are unilateral, especially if they're persistent, if there's recurrent epistaxis, crusting, or nasal pain, and finally, if there's discolored discharge alongside systemic features, these should all be investigated further. So the management of allergic rhinitis is actually very logical. The first step is allergen avoidance, wherever possible. If pollen is the trigger, advise sunglasses outdoors, showering after being outside, and keeping windows closed on high pollen days. For dust mite allergies, think bedding covers, washing bedding on a hot wash, and reducing dust in the bedroom. And for pets, it's about reducing exposure, especially keeping them out of the bedroom. For mild to moderate intermittent symptoms, start with antihistamines, either oral, non-sedating tablets or intranasal antihistamines. Common examples you'll hear all the time are cetirizine, loratadine, and fexofenadine. These work best for itching, sneezing, and a runny nose. If symptoms are moderate to severe or persistent, step up to an intranasal corticosteroid spray. This is the most effective treatment for nasal congestion. It is important that the patient uses this regularly, not just when they feel bad, as it can take up to 2 weeks for them to take full effect. If symptoms are still not controlled, consider a combined intranasal steroid and antihistamine spray. These are available in the UK and can be very effective when single-agent treatment hasn't worked. For severe blockage, a topical nasal decongestion like cyclomethaxylene can help, but only short-term. They should be used for a maximum of 7 days, as prolonged use can cause rebound congestion, often known as rhinitis medicamentosa. And finally, refer the patient if there's any diagnostic uncertainty or red flags, or if symptoms persist despite correct technique and adequate treatment trials. Complications of allergic rhinitis aren't usually dangerous, but they're common and very exam relevant. Ongoing nasal inflammation can predispose patients to acute sinusitis. In children, it can contribute to otitis media with effusion or glue ear, and poor symptom control often leads to sleep disturbance, resulting in fatigue and reduced concentration. Importantly, allergic rhinitis is closely linked with asthma. The two conditions often travel together, with rhinitis worsening asthma control. To recap, allergic rhinitis is an IgE-mediated inflammation of the nasal mucosa triggered by allergens, classically causing an itch, a sneeze, and clear rhinorrhea. And the best treatment for congestion is a regular intranasal steroid spray, with antihistamines for rapid symptom control. If you found this video helpful, please give it a like and consider subscribing for more clear, high-yield UKMLA content. Let me know in the comments which ENT topic you'd like next.